Well, thanks everybody for taking the time to join us today. I'm very happy to welcome one of my colleagues, Dr. Katherine Clark, to give a presentation today. Dr. Clark is an assistant professor of medicine here at Yale, and splits her time between the advanced heart failure and transplant cardiology service and the echo lab. So we thought she'd be a fantastic person to talk to us about the various forms of non-invasive imaging and how they're used to evaluate patients with heart failure. So Dr. Clark, thanks again, and really excited to see what you have for us today.
Thank you, Dr. Beasley. I appreciate it. And as he had said, my passion is advanced heart failure and cardiology, transplant cardiology, and then I spend the remaining time when I'm not on the floors in the echo labs. It's been an awesome blend to be able to be in both worlds, and obviously they go hand in hand. And I will share some pearls diagnosing advanced heart failure, and then some pearls that you'll go through your advanced heart failure year, and then as well as heart failure boards that are coming up. So I have no disclosures. And basically the agenda, I'm going to talk about appropriate use of guidelines and advanced imaging and things you'll, again, need for boards, really the advantages of echo. I am slightly biased. The growth of strain, multimodality imaging, and then pearls that you'll see throughout the year, and then some innovation things coming down the pipeline, and then advanced therapies and such we'll save for another day, given the meat of this here in our 30 minutes. But please feel free to reach out with any questions. So now, as everyone knows, boards, they love the guidelines. So I just want to highlight those and have them fresh in your minds. So imaging and diagnosing suspected heart failure, your strongest and primary recommendation is always going to be your transthoracic echo. Multi-center, numerous studies have shown that echo is important, and it measures the subclinical heart failure and then the risks moving forward of disease. And it's a great tool. Any provider, any PA, general practitioner, the echo allows them to diagnose a new heart failure disease. And echo is important. We use it along the continuum of, the entire patient's life: diagnosis, management, prognosis. We know it's very accessible, it's safe, it's non-invasive, and it's really the primary and most used modality for assessment of LV volumes and the ejection fraction. So in looking at asymptomatic screening, echo is almost always the first line. You will use CMR if you have suspected, infiltrative disease or things like ARVC, but everything else really, echo is your first line. There's serial testing to consider that may be necessary. For example, if you have primary relatives of patients with inherited cardiomyopathies, there's been no genetic exclusion, you're going to serially image those people. Or if you have genotype positive, phenotype negative patients, you're going to be, keeping an eye on them for the development of disease. We all know we have more and more patients on cardiotoxic chemotherapy agents and immunotherapies. They're going to constantly undergo periodic screening. And now we really use and really heavily rely on the 3D imaging as well as the speckle tracking, the strain, to really find that subclinical disease before the EF drops. And as we all know as well, with the diabetes, epidemic in the country and worldwide, these patients are at high risk. So even without symptoms, you're screening those patients, particularly in those with coronary artery disease, advanced stage hypertension, and then other vascular, long-term effects of diabetes, proteinuria, retinopathy. And then in asymptomatic patients, those that they have a new Murmuron exam or new ECG abnormalities. When we go to the more chronic heart failure patients, we know that that's where there's less benefit, right? Only a few studies have demonstrated that repeating echoes or MRs really change and show an improvement after medical therapy with imaging if the patients are stable. And really no studies show any clinical benefit for just routinely checking patients with chronic, non-ischemic heart failure. Moving to the ischemic disease, we know that more patients are living with chronic ischemic disease. That's increasing the prevalence of heart failure down the road. And looking at all our big heart failure classic randomized control trials, half to 2/3 of those patients, the heart failure is actually attributable to ischemia. And really, imaging you're going to use is critical to identify and then classify the severity of your ischemia, your coronary artery disease, and then also studies such as nuclear studies that really can help identify infarcted, hibernating myocardium to see really how to manage them in next steps, surgical management wise. Something else that's critical in advanced heart failure patients, and it always comes up on the board, is we know these patients benefit from primary prevention ICDs. And then when do we have CRTs? Not only do you use your ECG, but then again, your echo really is your critical tool to assess. Not only just the EF are we looking at, if the patient doesn't have the classic, prolonged QRS, bundle branch morphology, you can also see some degree of desynchrony and help, get that patient to get the ICD or CRT if needed. However, unfortunately, there's been some smaller studies, but then a larger randomized control trial with only echo-based parameters didn't show a benefit of who we could predict and respond to CRT. So now looking at some of the benefits of echo, and again, here I'm biased, but I think it's easy to see. So as I mentioned earlier, you're really going to use that echo along the entire continuum of diagnosing to managing these heart failure patients. You're going to first, look at, the EF, the volume, the size. I think as you'll go through your, advanced heart failure time, you're going to open that echo and just see some of those patients that are coming in with EFs of 15%. The chambers are all dilated. They're all down. The atria are dilated and the walls are thin. And you can just say, yeah, this patient's not recovering. They're going to need advanced therapies. So in time, you'll get that gestalt. But not only in that initial diagnosis or initial seeing the patient, but then obviously following them with disease as you get them on GDMT, it'll be crucial to see how they're doing. And then even looking furthermore at the prognosis, how much functional MR do they have? And I mentioned, how is the atria dilation? And you'll understand better the diastolic dysfunction, the synchrony, and all these things to see what these patients are doing, how they're going to do moving forward as well. Now, moving quick as a review, how do we quantify the LVEF? There's the 2D method, and the recommended way to do that is your Simpson's biplane. I say simply to the medical students and those coming in, it's like a stack of pancakes, when I'm on the wards with a general medicine residents. It's important to realize, though, that it does involve some geometric assumptions, and it's not as accurate. It's susceptible to off-axis imaging, and there is variability test to test. So just to recognize that it's a good tool, but not a perfect tool. And as we use more and more of the ultrasound enhancing agents, definitely improves the endocardial border recognition, and it does help with some of the assumptions when you are, measuring the EF. Then moving, if you have available, always go for your 3D method. It is the most accurate. It has the best precision and correlation with MRI, and it really alleviates the reliance on these geometric assumptions, which is great, but it still does have relatively low spatial and temporal resolution. And then stepping back, when we look at our heart failure classification, it still remains limited. In JCF, it was now a couple years ago, we further kind of subclassified HFrEF, and you have mildly reduced, or have classic HFpEFs, and then the improved. But I think we're still kind of understanding across all the different entities of the cardiomyopathies and heart failure. Is it really just a continuum? Are these really different entities? So we need to continue, obviously, to work and further learn to better phenotype different heart failure patients. So now I'm just going to spend a few minutes talking about strain imaging. It's pretty cool when you look at the physics behind it, I think. So just conceptualizing the myocardial deformation, how it normally works. The LV has 3 layers. There's the subendocardial, and the fibers are oriented in a rightward helix. The subepicardial, the fibers are oriented in the opposite way, as a left-handed helix. And in the mid, the fibers are circumferential. So these layers shorten and contract in opposite directions. So in some, you'll have shortening in the longitudinal and circumferential direction, but thickening in the radial direction. And then taking all that together, we look at the global longitudinal strain, and it's more sensitive than just the detecting LV dysfunction and just the EF. So it's calculated at looking at the average of the peak systolic strain in all the segments, in all the 17 segment model, in your apical, so your 4-chamber, 3-chamber, and 2-chamber views. But it is important to note that, like EF, it's dependent on loading conditions, so it's not pure contractility. And there are slight variations. More negative number is normal. Your borderline is really your 17, and 16 below is abnormal. Here, I just wanted to include a normal example from our lab. You can see it's tracking, well in your 4, 3, and 2-chamber views, and it matches up. You can see the map is all fairly homogeneous in color, and it is -20, which was a normal reading. HFpEF, on the other hand, your global longitudinal strain can be blunted. The circumferential and LV torsion are exaggerated. So your LV untwist, or, I simply say your heart relaxes, is delayed to patients. And thus, overall, your EF is preserved. However, in HFrEF, everything's decreased. The circumferential, the radial, the torsion, untwist, everything. So it really shows that everything's exhausted and the heart can't keep up anymore in any compensatory mechanisms. And here, just a slide to note that GLS really can provide independent prognostication. So in HFpEF, just to highlight some recent trials, TopCat showed that a reduction of strain was the most important echo marker of predictor of death or heart failure, so bad outcomes. And then in Paramount, the strain was significantly impaired in patients with HFpEF, as opposed to those with just hypertensive heart disease. In HFrEF, in numerous studies, they found that it's an independent predictor of all-cause mortality in heart failure patients. So definitely important to note, and I always try to include it when I'm reading studies when it's obtained, or if I'm worried about it, the tech can go back and get it for me. So I think we focus a lot on LV strain, but I just wanted to raise your attention that we're looking at strain of the other chambers. More and more we're doing RV and then even left atrial strain. We know that, the larger left atrium marker of LV filling pressure, increased cardiovascular risk for these patients down the road. So looking at not only the volumetric data that we obtain, both 2D and 3D, adding the strain into that, you're really understanding and better seeing the diastolic abnormalities of the LV. With that, adding the information from the left atrium as well. So coming more and more, they're not something we do regularly here in our lab. So now a few just disadvantages in echo before I go into the other more modalities. Obviously, it requires additionally highly skilled personnel. You can say in our echo lab, we really highly depend on our echo techs. If we don't have good echo techs, we don't get good images. So something that's very important to us is getting the skilled people to obtain these studies. And then often, as we'll see in the advanced heart failure world, its images are limited by the patient's body habitus. For example, if they're post-op in the CT ICU and they had their LVAD placed from the cannula and they have the chest tubes in, makes it tough. And then it is also harder to obviously see posterior structures. That's when you'll need your transesophageal echo. One thing to note here is that echoes, we often get a lot of consults for, the pulmonary hypertension, RV dysfunction patients, and to remember that PA pressures are very highly unreliable. They're half of them are inaccurate in numerous studies when you compare to right heart cath. So always, when you're concerned about pulmonary hypertension, don't rely on the echoes. Really, kind of seal the deal and get the information from the right heart cath. I know when I'm reading, so many of the times my tricuspid regurg jet is just insufficient to evaluate. Okay, so now taking a step back and moving into CMR for heart failure. So I think more and more, and I've even seen in my training, we're utilizing CMR to look for the etiology of heart failure patients, infiltrative diseases, and the non-ischemic patterns, looking for what other information we can find, especially when the echoes are inadequate. I think importantly, there are numerous benefits. It's becoming more accessible. It's very accurate, reproducible, an unrestricted field of view, so the body habitus doesn't come into a problem. You have no ionizing radiation. And I think the real benefit is really the tissue characterization, looking for edema in myocarditis, for example, looking for scarring, looking for iron infiltration, and really, and all that important data that we can assess, really only with the MRI. And more from our transplant population, I think we're using it as an additional tool for situations when we can't use, endomyocardial biopsies to really look at the cardiac allograft function. And it can be cost effective and obviously less invasive. So in the right patients, I think we're learning more and getting a sense of, how and when we can utilize this strategy in addition to our, cell-free DNA technologies as well. However, there still are some downsides to CMR. Relatively compared to the echo, it's a more limited availability, it's more costly. It's more complicated when patients obviously have, ICDs, CRTs to help, manage those settings. And at Yale, we do them on certain days, so that limits their availability. And then patients often can't tolerate MRs. They have a problem with, being in the machine for a lot longer, and then just the technical aspects of it. If they have AFib or they have lots of ectopy or wide QRS, it makes it hard to look at the images. And then also with significant renal dysfunction, it makes it tough as well. Not an issue in echo. And we all know that a lot of our heart failure patients do have a good amount of renal dysfunction associated. And then just one quick note, I think I've seen in my training just more and more use of the coronary CTA to diagnose and look at ischemic disease, now a class 1 indication in the chest pain guidelines, and really using it more and more for kind of ruling out those patients that I'm not super concerned with an ischemic cause of their disease. And I think as more and more we get FFR in use, we'll only continue to use it more. Okay, so now I just wanted to talk about some imaging pearls for some specific syndromes. And again, this is really focused for some pearls for your heart failure year as addition to board studying coming up. So for HFpEF, one important thing to note, diastolic dysfunction isn't required for the diagnosis of HFpEF. It's often misinterpreted and there's limited information. And the guidelines are a work in progress. And you can obviously have HFpEF without diastolic dysfunction. And it's good to remember that the echo is always obtained at rest. We're doing more and more of our level C3 CPETs, which I think is very helpful in elucidating some of these tough patients where you think they have heart failure, but you can't kind of, nail down the diagnosis. However, if they do have moderate to severe diastolic dysfunction, I think that really can be helpful in aiding your diagnosis of HFpEF and treating them. Some important things to note that even if you do have the established diagnosis of HFpEF, if they have what their strain is, right, it'll kind of guide you maybe more in one management versus another. So if you have HFpEF with a reduced strain, maybe more triggered to think of an infiltrative cardiomyopathy, some microvascular dysfunction, versus HFpEF with the normal strain, more vascular stiffening, is it a left atrial dysfunction, RV, extracardiac? So kind of helps guide you along the path as well, how to best treat these often very challenging patients. Okay, moving on to amyloid. So in the echo, you will classically see very thick walls. You will often see these speckled myocardium. Seen it, numerous times, even just the couple years that I've been faculty and reading more and more echoes. And they often do have some degree of a pericardial effusion. There's the 555 sign. Basically, all your tissue Dopplers are reduced, systolic, early diastolic, and late diastolic filling. So very, very low overall. Moving on to the CMR, you'll get diffuse subendocardial LGE, hard time nulling the myocardium, and then increased ECV on your T1 mapping. So if I'm at all concerned, I think what's nice is, and especially important with imaging, is going to the lab, talking to the readers and really getting a sense in the challenging cases. I think that conversation always really helps. And add a practical pearl in. And then importantly, with TTR amyloid, you're going to have your pyrophosphate scan, looking at that and the different grades of visual uptake for your positive studies. And then a few, again, board pearls, don't be fooled in real life or on the boards. You can have false positives when they have AL amyloid, a rib fracture MI, and then something that probably was more on the radar with the pandemic, but a hydroxychloroquine toxicity. And then false negatives in early disease, as well as certain mutations actually too. Okay, moving on to sarcoid. So some classic findings for sarcoid to be aware of. You have focal aneurysms all the way down to dilated cardiomyopathies. And then on your MRI, you can have focal, multifocal, or extensive LGE. So the whole gamut obviously on both imaging modalities. Importantly, you're going to want to obtain your FDG PET. It's also helpful to look for active disease. And the most challenging part is you have the patient to eat the high-fat, low-carb diet the day before the test. I think together with the MRI and the FDG PET, you can really classify the phenotypes, whether they have no active involvement. If they're a burnt out cardiac sarcoid, they have disease scarring on the MRI, but a negative PET, or if they're both positive, where they have active cardiac sarcoid with inflammation going on. I think it's really helpful to get a sense of how to best treat these patients, and often young and very sick patients. So here was just a nice diagram too of looking, helping imaging, saying what's this diagnosis of HFpEF. So I'll kind of click back and forth. So first kind of look at A, and then there's your classic thickened myocardium. You have your cherry on top, which you'll know for boards, and your TTR amyloid. Going back to B, looks fairly bland, nothing in particular, kind of mildly diffuse LVH, maybe some atrial enlargement. Here we have an restrictive cardiomyopathy. Again, just some interesting findings, maybe slightly decreased strain along the septum more so. And then in C, more apical hypertrophy, kind of opposite of the cherry on top, it'll be your apical HCM. And then again, kind of a diffusely not exciting, some hypertrophy in D. Something like end-stage renal disease, for example, can always fool. I've had numerous patients too. Okay, and then in the last few minutes, I just wanted to touch on some trends moving forward. And they've been in the works, but I think are finally getting better. I think the technology is really improving. We're having more handheld devices. I know the medical students already have learned a lot more echo and have early on in their medical training than I did when I was a medical student and resident. So I think it's getting better and better. I think it's helpful in the units when you're looking, instead of getting big studies or more hemodynamic right heart caths, the echo is really helping at the bedside. Obviously, in areas with less resources and remote geographies, I think it's finally becoming feasible. Even people in our department are working how to incorporate, getting the technology at the bedside, and then how to help long distance interpretation even. there's more and more companies and small companies, in addition to the big companies like Philips, for example, really how can AI help not only take the measurements, but help the people and the techs acquire images. So it'll show you how to move the probe. It'll judge the quality image and say, counterclock or clock. So I think we're only at the tip of the iceberg for how we're going to have AI help both acquire images and interpret them. And again, I just threw this in here. People are working on this to really define how best to improve these AI enhanced pathways for people that don't have a lot of expertise and don't have great techs all over the world, be able to get images and get patients the help they need. One more aspect of AI, again, I think we're just at the cusp. Something we're working on, in our lab. For example, this is, radiomics, really, how do you extract data from the multimodality imaging to better diagnose and prognosticate patients? And I think the traditional way is to do that more manually, but AI will really only help us with all those middle columns and really extracting, vast array of information and really intricate, more subtle, variations that our eyes can't. So I think it'll really help, hopefully better phenotype heart failure, and then how patients will do and what treatments to give them. Here, just another example, phenomapping, again, using AI to really pull out and interesting information, clustering different data, both clinical and then from the echocardiogram and CMR. I think we're only, again, at the crux of what we're going to do and learn with machine learning AI and our imaging, in addition to the clinical tools. So just in some, multimodality imaging and advanced heart failure, it's always the answer. It's really, your echo is your cornerstone, but everything together you're going to need to kind of find and, pinpoint that diagnosis for that patient and then managing them moving forward. So I think in my role, I love it because it's very multidisciplinary, comprehensive, and you're working with everyone. With heart failure is fun from all the different subspecialties and talking to them on a day-to-day basis. So to really help get the patient the care they need. So I think, again, just to reiterate that it's important to not only diagnose it, but then following them, managing, helping them. We want heart success for function, not failure, the new catchphrase in our field. And I will end it there with any questions. If there's anything else before, I guess I will ask for questions. I will put a plug in for those fellows, trainees, anywhere along the way, young faculty. I'm part of an organization called Women in Transplant and Mechanical Circulatory Support. And it's been a fabulous network of women around the world in advanced heart failure for mentoring. And so it's witmcs.com. Women it's focused on, but men are welcome to join. And also pharmacists, echo techs, coordinators, anyone, and Ps, APPs, we're happy to, help empower women and everybody and trainees in the field to grow. So I will end it there and now officially open for questions.
Thanks, Dr. Clark, on a fantastic talk. Anybody have a question for Dr. Clark? Please feel free to unmute yourself and ask the question. Or if you are unable to unmute yourself, you can place it in the chat and I'll ask it for you. I guess a question I was going to have for you is, based upon the data that you presented with strain imaging, and, in our order sets, we always have to go about and state that, we want strain imaging to be part of the evaluation when we order a transthoracic echo, I guess. Do you feel like really all imaging for anybody suspected of heart failure and with known heart failure should always have strain imaging, or is it sometimes is sometimes too much for the techs to do, or requesting too much from them? I guess if you see where my question's going, I'm kind of wondering, like, say at one point I was requesting it for everybody, and then I started not doing it, and I'm just kind of curious about where that threshold might be.
I think I've been lowering that threshold. It's something they can do retrospectively. So even if the patient has left the lab per se, you can add it on or even if you get the study and want to know about it, you learn about the patient a little more. I think it's fine. And I know personally with our lab, where it's going to be, I think, incorporated with AI, and we're working with both Philips and smaller companies to, get those automated measurements so that the techs even aren't spending time. So I think it'll only be a matter of time until it's obtained in all of our patients. But I would say keep your threshold pretty low, other in a new diagnosis or change in clinical status, compared to just your stable, not ischemics that are doing okay.
Well, if we don't have any other questions from the group, Dr. Clark, thanks again for taking the time to present this for us. I did leave the lecture survey in the chat, so if those attendees, if you have a moment to fill that out for us, we'd appreciate it. And otherwise, we'll be in touch. And next week, we're not going to be having a talk because that is the wrap up of the Heart Failure Society of America meeting. But we'll get restarted again back in October. So we'll see everybody then. Thanks so much.
Thanks. Bye.